Oasis. I thank everyone for sharing your valuable time. But I promise that your time won't get wasted because you are going to have an academic feast by eminent speakers Dr. Durga and Dr. Narasimha Reddy sir. Shall we have the lamplight ceremony?
I request Dr. Vijayabhati ma'am, Dr. Durga Rao ma'am, and Dr. Rekha, Dr. Padmapriya for the light jumping. Please join us. Dr. Jigna, Dr. Narasimha Reddy sir, please join us. Dr. Jyoti and Dr. Grishma, please join. Come for the lamplight. Dr. Manasa. Sir, please.
స్టార్ట్ చేస్తున్నారు
వాటర్
ల్యాంప్లైట్ తర్వాత డాక్టర్ జిగ్నా ఫస్ట్ స్లైడ్ అని పెన్ డ్రైవ్ కాల్ చేసి
ఏది
ల్యాప్టాప్ నుంచి
ఇంట్రో స్లైడ్స్
ఇంట్రో డాక్టర్ జిగ్నా ఫస్ట్ స్లైడ్
ఓకే
రెండే స్లైడ్
రెండే స్లైడ్
సంస్కృతం
శుభం కురుత్వం కళ్యాణం ఆరోగ్యం ధన సంపదః శుభం కురుత్వం కళ్యాణం ఆరోగ్యం ధన సంపదః శత్రుబుద్ధి వినాశాయ దీపజ్యోతి నమోస్తుతే దీపజ్యోతి నమోస్తుతే దీపజ్యోతి పరబ్రహ్మ దీపజ్యోతి జనార్దన దీపజ్యోతి పరబ్రహ్మ దీపజ్యోతి జనార్దన దీపో హరతు మే పాపం సంధ్యాదీప నమోస్తుతే శుభం కురుత్వం కళ్యాణం ఆరోగ్యం ధన సంపదః శుభం కురుత్వం కళ్యాణం
నాకు ఇచ్చేసాను నేను పేస్ట్ అయినా చేస్తాను ఇది ఇచ్చినా పర్లేదు
శత్రుబుద్ధి వినాశాయ దీపజ్యోతి నమోస్తుతే దీపజ్యోతి నమోస్తుతే దీపజ్యోతి పరబ్రహ్మ దీపజ్యోతి జనార్దన
ఇప్పుడు వేయాలా రెండు స్లైడ్
మేడం స్లైడ్ జిగ్నా ఫస్ట్ స్లైడ్ జిగ్నా మేడం డాక్టర్ జిగ్నా ఫస్ట్ స్లైడ్ టూ స్లైడ్స్
అందులో కావాలి
సెట్ చేసి పెట్టలేదు యాక్చువల్లీ.
Good evening, one and all.
అందులో
Annadanam param danam. Vidyadanam ataha param. Annena shanika trupti. Yavajjivam cha vidyaha. ఇదొక సుభాషిత. ఇందులో what I understood is that annadhanam, when we give food to someone, it satisfies them temporarily. So they satisfy their hunger only for a limited while. But somebody who's giving us knowledge, vidya dhanam, that helps us throughout our lives. So today we are having eminent speakers between us, Dr. Durga Madam, as well as Dr. Narasimha Reddy sir, who are going to share their, little bit of their vast knowledge of ocean of knowledge with us, so that we can, help our patients in a better way. So before we get into the academic feast, I would invite Mr. Kalyan, who will be telling us about Oasis Fertility and his journey.
కళ్యాణ్ సార్ సార్
Good evening, everyone. Thank you, Dr. Jina. I would like to first thank COGS team for allowing us to conduct this art conclave for the evening. I would like to thank Dr. C. Vijayabharati, President COGS, Dr. E. Naini, General Secretary COGS, and Dr. G. Ratnaka, Staff, President COGS. And a special thanks to Dr. Narasimha Reddy for placing this occasion. So quickly, I will just go through the journey of Oasis till date. Oasis Fertility is incorporated in the year 2009 by the founders, first generation entrepreneurs, Dr. Durga and Mr. Kiran. We have over the years grown and have gained the trust of most of the gynecologists and the patients. Right now, we have 32 centers across India. And we are now more or less predominantly a major player in South India. We call ourselves, we are the first number one in South India. So our founders are the first generation entrepreneurs who have been the core pillars for Oasis journey till date. Dr. Durga Rao, who is our MD clinical, and then Dr. Mr. Kiran, who is our technical co-founder. He's been the innovation and the technical pioneer for Oasis Fertility. Let me just quickly take you through the journey of Oasis. Oasis journey and the growth can be segregated into a couple of phases. Phase one, wherein we have started our journey in Andhra Pradesh and then predominantly between Andhra Pradesh and Telangana. Later on, we have started moving into other states, into Gujarat, Maharashtra, and Bhubaneswar. This is our phase two journey where we have actually moved out of Andhra Pradesh, which is our home ground. Although we have expanded to 32 centers, the core and the DNA of Oasis remain the same, predominantly because of our core medical team, where the SOPs and the quality has been given the emphasis. And this ensures uniformity of our treatments and protocols across all the clinics in India. Our core medical team is spearheaded by Dr. Durga and Dr. Krishna Chaitanya, who is our scientific head. What we do at Oasis is rewarded, and then we are just focusing on what we do, and outcomes are something which is acknowledged by the fraternity. We only focus on what we can do and what we do at Oasis as a clinical processes, and awards and achievements are an outcome of what we do at Oasis. We have been awarded the best brand for fertility, and then we have been awarded the fastest growing company by ET now. And these are just our achievements and outcome of what we do at Oasis. We lead treatments and we are different to our competitors. Why? Because we have a state-of-the-art facility and our labs are having and equipped with cutting-edge technology. And our treatment to our patients, we have a holistic approach in treating our patients. Instead of taking same treatment across all the patients, we actually understand a lot about our patients and then craft a treatment very particular to their requirements. Our whole idea is to create a wow factor for our patients in the clinic. So be it the front desk to the clinical team to the embryology team. Every touch point of the patient, we emphasize on creating that wow factor within the clinic. Now coming to our ethos, most trusted brand, it just cannot happen overnight. So our focus and our hard work for the last 14 years has earned this trust in the fraternity. We are the most trusted brand and it's based and we actually give customized treatments to our patients. And all our treatments are evidence based. So we actually try to give the biological child to the couple. Our core values: compassionate, competent, customized treatments to our patients, compassionate, being compassionate with the patients, and confidentiality of patients. We retain confidentiality at all the levels, all the touch points of the patients, and we are committed to deliver the best in the industry.
ఇందులో రెండు ఉన్నాయి.
Just give you a glimpse.
ఒకటి సెప్టల్
we have
ఫస్ట్ యూటరిన్ ది పేజ్ యూటరిన్ అని చెప్పేసి ఒకటి ఉంది, ఇంకోటి సెప్టల్ అని ఉంటుంది. ఫస్ట్ యూటరిన్ నేను మీకు
And we
ఇచ్చేసాను.
have close to about
మళ్ళీ ఎప్పుడు ఇస్తారు?
85,000 happy families over the last 8 years. And we have collective experience of 300 years.
ఎప్పుడు వెళ్తారు?
And this is just not it. We are an organization more than 900 employees till date. We have been, as I told, we have been labeled as the Oasis Fertility in South India. Fertility clinic. We are an FOGSI certified organization and a QI accredited. We are a member of ASRM and FOGSI. Why are we different and how is it we are different? So our heart of our treatment lies in our IVF labs. And we have got the state-of-the-art best of the facilities and the equipment in India. And we are proud about it. We have centralized AHUs with HEPA filters which actually create a class 10,000 environment in our IVF labs, which helps us in getting the highest success rates. We also have witnessing system which ensures that we don't actually have any sort of error, don't leave any sort of error for any sort of gamete. And we use consumables which are MEA tested for toxicity. This helps us in providing the best quality service to the patient. Coming to our success rate, this is just an outcome of what we do and what we follow as our best practices at all our IVF clinics. We have the highest success rates so far and predominantly are driven by our practices. And coming to our Karimnagar success story, with a single transfer IVF, we have a success rate of 70% and overall success rate of about 74%. At Oasis, we actually are constantly upgrade ourselves with the latest technologies. We use microfluidics and embryo growth, so for us to actually improve and increase the quality of service for patients. And how do we collaborate with the gynec and the fraternity? We actually collaborate with our gynec doctors. We don't see them as our doctors, we see them as our partners. We actually, our gynec doctors refer patients and we actually refer back the patient after the positive outcome. This is how we maintain that partnership with Oasis. Artist is an IT software that we use, which is the backbone of Oasis. Through Artist is how we actually maintain the best of the quality at Oasis and uniformity of service across all the clinics in Oasis. Artist has been we have used cutting edge technology which actually helps us in providing the better options to improve the success rates. Artist is again backed by AI that we are building in house. We also look at male fertility clinics, which is under the brand AndroLife. We provide advanced tests and surgeries for PISA and TISA, micro TC, and vasectomy. These are our additional services that we provide at Oasis. Fertility check is a unique concept that we started in Hyderabad, wherein we have done essay at home, and the reports are generated within 30 minutes. So this is something we have done in Hyderabad, and we are planning to scale it up in metros in Pune and Bangalore. Another new initiative that we've taken at Oasis is Ask Oasis, which is again an in-house built application, which is an artificially improved AI-backed fertility Google search that we use. I mean, anything and everything that a patient wants about fertility treatment, they can actually come out to this page and then they can ask. So this is the answers that are provided in this portal are backed by our research at Oasis, and they get more clarity about the IVF treatment as such in India. Next, our CSR initiative is Amulya. We actually provide free of cost IVF treatments for needy, and this is something we do, and we believe that we have to give back to society. The core to Oasis and how we are different from other players. We have been very focused on our learning and academic training institute. We are proud of our training institute, which is Oasis School for Human Embryo and Reproductive Medicine. We call it as Ocean. We actually offer long-term and short-term courses in our training institute. So if anybody is interested, probably please do let us know. And thank you all for coming. And it has been a great pleasure seeing you all. I would like to thank you for being here today. And without any further delay, I would like to call Dr. Chikna, and probably we can take it off from here. Thank you.
It's a great privilege to introduce a dynamic, hardworking, and a great visionary, Dr. Durga Ji Rao, who is a co-founder and medical director of Oasis Fertility. She is a fertility specialist in reproductive medicine and minimally invasive surgery with an overall work experience of 26 years. Before Oasis, she has practiced in United Kingdom and Canada for 12 years. She is a whatever newer modalities come into the field of fertility, I think Oasis will adopt all those newer technologies. So she is a pioneer in research and practice of in vitro maturation treatment and fertility preservation. She has been responsible for introducing CONCLAVE, that is association in vitro maturation and advanced fertility treatment in India, especially for women with cancer, polycystic ovarian syndrome, resistant ovary syndrome, thrombophobia, and suicide maturation problems. She is a passionate teacher. Dr. Durga has set up an exclusive academic and research wing, that is Oasis School for Human Embryology and Reproductive Medicine, which provides hands-on training to gynecologists and fertility specialists through exclusive curriculum and simulation modules. She has numerous papers and publications to her credit. With just one center which has been established in 2019, Oasis Fertility has grown up to 32 centers across India because of her hard work and ethical practice, I feel. So I welcome Dr. Durga to
In terms of your introduction, you called me a very passionate teacher. In fact, aggressive teaching nowadays. So we get our students, and it's like lock in for 3 hours on a Thursday and 2 hours on a Tuesday. They are not allowed to even breathe outside that confines. So it's more of a passionate. I think I'm going towards aggression nowadays. Like take a stick until you learn you're not going out of policies kind of thing. So people actually, worry. Then they look for fellowship. Am I going to Banjara with another doctor, or shall I go for somewhere which is much more safer, where I won't be shouted at every day? So I think there's a lot of competition for other centers than Banjara because I can stand the aggression. Coming to today's topic, no ovarian reserve. I just renamed it a little bit in saying that what can we do to look beyond the option of a donor? Now here again, like when we read about CONCLAVE, I think for students we keep telling them there's a stark difference between CONCLAVE resistance and CONCLAVE failure. Very distinct difference. Similarly, when we are talking about ovarian reserve, again there are two distinct features of this. One is somebody who's got a poor ovarian reserve or a low ovarian reserve. So reserve here is the most important word. When we are talking about reserve, we are talking about somebody who's got a low AMH, who's got a low AFC and a raised FSH. Versus the other concept, which is a poor or a low responder. Now, the distinction between these two is the most important aspect, which is the reserve. When we are talking about poor ovarian reserve, they've got a reserve which is low. But a poor responder may not have a poor reserve, but their response to treatment is poor. So they are very distinct. And why is this distinction important? Is because the treatment absolutely is different for these two. So how do you manage a poor responder? Now this is the most challenging task that we have. If there are no eggs donor, if you have eggs, we'll go ahead with yourself. But somebody who's got it but not responding is the gamut that we have to really look about in terms of how best we can evaluate them and give them the best success. Now, this is not a small problem. In fact, in today's OPU, we see at least 30 to 40% of our patients come under this category. And as time is going by, we are tending to see a lot more of these people in their younger age. You would expect somebody who's crossed 40 to have a poor result. Absolutely. You would also expect them to have a little bit of a poor response. But what do you do when you have a late 20s or an early 30 woman coming up with a poor response or a low ovarian result? It is completely defying nature also in terms of seeing those young people with that kind of a response. Now, poor response, as opposed to poor ovarian reserve, there are a few things as a specialist that we have to look at. How can we call them poor response unless we ensure that at least these four matters are taken into consideration? One, have you given the right dose of medication? You give somebody a lower dose of 150 or 225 and expect them to give you, a good response to it? Probably not right. What if you're giving a poor quality medication? Has the cold chain been maintained? Are we giving them adequate, quality medications? The second point. The third point, a woman whose BMI is around 35, 37. If you give her a lower dose, how much is going to respond? Obviously, based on her BMI and age, you have to up your dosage as well. So, is the absorption a possibility? Patient errors. Sometimes some of our patients say that we can't keep traveling to the hospital every day. We'll take it at home. Are they, or they get a nurse to do it? Now, their nurses are obviously not trained with the pen or anything, in terms of dilution. Are there any errors from the patient aspect which has contributed to the poor response? So before you can see it is a patient factor, we have to eliminate all of these which are actually iatrogenic and not patient. Now, initially, when we were talking about poor responders or poor ovarian reserve, we had the criteria of Bologna, but it was very superficial. And here there are two aspects. They are looking at only women who are more than 40. What about the ones who have crossed 37, 38? They also actually come under the category of having poor ovarian response. And their other thing was if they've had a previous stimulation and if they had less or equal to 3 oocytes. Now that has also undergone some change. And then the third thing is if they've had any abnormal ovarian reserve tests. And you're supposed to have only 2 of the 3. Obviously, if somebody is more than 40, they will have poor ovarian reserve. Does that still make them a poor responder? Probably not.
If they end up with 4 follicles and you're able to extract 3 oocyte, that is not a poor responder. That is somebody who's already got a poor ovarian reserve, obviously because of her age. So this distinction between response and reserve was not actually taken care by this criteria, which is why the more established criteria, which is what all of us have to look at, is the Poseidon criteria. Now here, very distinctly, they have actually changed a few things. One, correctly so, they have reduced the age from 40 in Bologna to 35 years, which is what is possibly accurate when we are really looking at how our patients are behaving. The second thing is that they also looked at AMH. In Bologna was 1.1. Here they have increased it to 1.2. And the third thing that they also looked at is they categorized the group based on the age. Yes, but they also categorized them based on the other aspects. One is group 1. Here you have good reserve but low response. See, this distinction wasn't there earlier. So here we are looking at group 1, which is young, which has got good reserve. But when they went in for a stimulation, they had a poor response. As opposed to group 3, wherein the patients are young, but they also have poor reserve. So this reserve and response was taken into consideration in this classification. And again, group 2 was somebody who had a poor response versus group 4 who had a poor reserve. And these 2 categories were very clearly distinguished in this. Now, this enables you to actually categorize a woman specifically as to whether she's got a poor reserve or a poor response. Now, when we are talking about pregnancy, why are we talking about low reserve, this and that? How does one be called as a poor reserve or a poor response? Ultimately, what are we looking at? We are looking at live birth. What contributes most to live birth? Please say age. Because if I had a lineup of people and they all had same AMHs and they had the same AFCs, I would still want to pick the one who's youngest. Because irrespective of her AFC and her AMH, she will give the best chance everything. Second, it's not AMH, it's not AFC. Those are the indicators for us. But bottom line, like the theme of this conference is, it's what inside that counts. Age tells you what's inside. Second, number of eggs. Your AMH and AFCs are tools that we use to counsel patients. But in our chamber, when we are alone and we are looking at a file, what is it that we are looking at? How many eggs is a patient going to produce? Ultimately, that's what it is. So when we're really looking at the number of eggs that a patient can produce and what their chances of live birth are, as you can see, starting from 15 to 25, they're almost flat. That gives you the best success rate. You don't need more than 25. In fact, more than 25 means that the quality of the oocytes are poor. That's why your pregnancy rates are coming down. So 15 to 25, though it is a large number, but at least when you're counseling patients and when we have patients coming in for fertility preservation, somebody who's young, doesn't want to get married now, who wants to take some time to get married. The first question she asks me is, how many eggs should I freeze? 15. Minimum. That gives you the best success rate. Now, for us to identify, we can identify somebody with a low AMH, a low AFC age, all of that. They're, very evident markers. But what other things, as gynecologists, before we become fertility specialists, we have to think like a gynecologist. Not everybody needs specialist care. So as a gynecologist, when you have a young adult or you even have an adolescent, what is it that you should be looking at? For you to identify these kind of people who need extra special care, one, most importantly, timely care. Now, if she's had somebody who's got bilateral endometriomas, we are going and doing cystectomies because she's got pain and these cysts are big. She sees you, you do a cystectomy, she sees somebody else, they do another cystectomy. And then after a few years, they come back with an AMH of 0.1. What should have been done? We all know endometriosis is a progressive disease. If you're seeing recurrence, if you're seeing bilateral disease, we as gynecologists have to think about the fact that she might go into low ovarian reserve. Consider fertility preservation. She might be in her early 20s, agreed. She might not think about fertility for at least another 8 to 10 years. Agreed. But by the time she starts thinking about it, what is the outcome regarding the treatment? What are the chances that she will be able to produce good number of eggs? Low. So that's when we should be identifying these people so that we can predict that they might go into ovarian reserve and give them the necessary education in terms of fertility preservation. So the first thing is prevent infertility rather. Like how we are going for preventive medicine, I think infertility also in a lot of aspects there are preventive features that we need to identify. So how do you prevent infertility for this person is how you need to identify the risk factors first. How do you predict poor ovarian reserve? How can you modify their response in a cycle so that they don't become poor responders? They're already poor reserve. We have to eliminate the response aspect from them. Don't make a poor responder or reserve also become a poor responder. So what are the adjuvants that you give them? How do you individualize IVF for them? How should the lab take care and we produce the best outcomes for them? And also how do you tailor make the embryo transfers? So first aspect is identifying the risk factors. Again, like I said, endometriosis, bilateral dermoids, autoimmune conditions like SLE, family history of premature ovarian insufficiency, mother goes into premature menopause. Very likely this is something that is going to go down the generations as well. If they have had any kind of extensive pelvic surgery, if they're going for radiotherapy or chemotherapy. So these are the factors that immediately we have to think about. What is the future sequelae for them? We as a gynecologist, we cannot be thinking about the next year or two. We have to think about the reproductive span. If not the reproductive span, we also have to think about the hormonal life. How many of them are actually requiring HRT? How many are being advocated HRT? Why should we do that if we have options? So it's not just about fertility, it is not just about eggs, it is also about their hormones. Ethnicity, another factor which we also have to remember is if you have a 32-year-old Caucasian, if you have a 32-year-old Caucasian woman, your 26-year-old person behaves like a 32-year-old Caucasian. So we are behind. I said this wrong, sorry. A 32-year-old Indian woman, a Caucasian who's 38 will behave like an Indian 32. So our reserve, our response to treatment, our possibility of becoming poor responders and ovarian reserves is much quicker. Whether it is the environment, whether it's the diet, whether it's the genes, we don't know. But the fact is that we are much lower in the scale than a Caucasian. Genetics. Please rule out any premature menopausal family, fragile X retardation, Turner's syndrome, FSHR receptor polymorphism. These are the people who have genetic conditions that are going to make them, go into the poor reserve category. Autoimmune, like I spoke to you, is the autoimmune syndrome. We are also talking about adrenals, thyroids, or thyroid disease. Now, again, the first slide I showed you how many oocytes we need. Each oocyte is important. Though we are talking about 50, not everybody has 15 oocytes. What do we do for the ones who have lesser chances? Every egg is important. That is why even if a person is developing 2 oocytes or 3 oocytes, we still say, please go ahead, because each oocyte can increase your live birth by at least 5%. Now, how do you manage? Like I said, because the Poseidon criteria divided them into poor reserve and poor response, let's look at poor reserve. There's nothing much you can do. But there is a lot that you can do for the ones who have not responded very well, who have got a good reserve. Their AMH is good, their AFC is good. The number of follicles that you're seeing, all the reports and everything is fine, but they still don't respond adequately. What do you do in that group of people is the most important aspect that we have to look at. And what is the reason? For us, a treatment obviously is because of what is the cause. You look at the cause, you'll get the treatment. What is the cause? Most of it is because of the polymorphism. So here is where you have to increase your gonadotropin dosage and give it for a longer time to get the same kind of response that the same age, same reserve patient would have got otherwise. We also have to look at the lifestyle. We have to improve their lifestyle, reduce the oxidative stress in their system so that we get better outcomes. So higher doses, add LH, give them for a longer duration, synchronize the follicles because each follicle might have a different sensitivity index. Not all follicles, even though they're all at let's say 7 or 8 millimeters, not all of them will grow. If you have 4, maybe 2 will grow, maybe 1 will grow, which means that each follicle has its own sensitivity to the FSH. So how do you get them to synchronize so that you can do the best in terms of recruitment? Relook at your trigger strategy. If the trigger is optimal, is when you will get mature oocytes. So please, it's not just about what happens before the cycle, during the cycle, but even the trigger is extremely important for you to get the best outcome. And if it still doesn't work in increasing oocyte output, then look at pooling embryos or going for gathering more oocytes. Now let's look at whether there is an ideal protocol for poor resolve or poor responder. The answer is no. It doesn't matter whether you're doing an agonist protocol, whether you're doing an agonist stop protocol, you're doing a flare, you're doing an agonist, whatever it is, all the evidence points out to the fact that there is no difference. Whether you go for an agonist or an antagonist protocol, any protocol that you choose for should be based on the number of follicles you see and her response and her baseline hormones. That's all. Now, next question is, I have somebody who's got only 4 follicles. How much dose should I give? 300, 450, 600. There's a distinct change of the gonadotropin dosage in the 2 continents. Europe, very conservative. They don't go beyond 225, 300. US, they look at the woman, they look at the BMI, they go up to even 600. So when the study was done, they looked at the comparison and they found that, as you can see, the live birth, it made no difference if you went even above 300. And that is what even H-rate tells you. So gonadotropin dose higher than 300 is not recommended for predicted poor responder. So each word is extremely important. So here we are talking about predicted poor responders. Who are the predicted poor responders? People who have got low ovarian reserve. So let's not get confused. If you have somebody who's got a low reserve, go with 300. If you have somebody who has a poor response, this doesn't hold true. So even when you're interpreting guidelines, you have to understand what and read between the lines. So in somebody low reserve, 300 best. Somebody with poor response, you might have to go higher. In a step-up protocol also. Now, what are the alternate approaches in these poor responders? Adjuvants. So preparation of them even before they go for an IVF cycle is extremely important. How do you prepare them? You first ensure that you don't suppress them. So giving them the pill, giving them blue pride and all of that, you're suppressing them. There is no reason to do that. But instead, work on them in the previous cycle. Give them DHEA, give them growth hormone, give them testosterone gel. All of these are known to improve. If required, give them a luteal estrogen supplementation so that you can synchronize the follicles. So I've given you 4 choices: DHEA, testosterone, growth hormone, as well as luteal estrogen. So these are the different ways that you can try and improve their response in the forthcoming IVF cycle. And again, there are various reasons, and we can go into the mechanics, but a luteal E2, basically what it does is, it doesn't allow the FSH to rise up in the pre-menstrual phase so that all the follicles are synchronized. You do not get them to, gain any kind of dominancy in the cycle life. So it synchronizes all the follicles. Very cheap estrogen tablets, only for 7 days. And it is patient friendly as well. The second thing is NH supplementation. As the response of the ovary comes down, what we have to understand is that only FSH does not help. You have to have a component of LH. So HMG or Pergoveris, which has both LH with FSH, those are the medications that you should be using more of than the recombinant FSH or the highly purified FSH. And again, all of this has been proven in terms of all the studies, the meta-analysis as well as the reviews. What about growth hormone? Growth hormone also, what it does is it makes the follicle more responsive it sensitizes the insulin-like growth factors which are there on the follicle, which helps to actually absorb the gonadotropins that you're giving so that they can respond better. Again, you can also use them as a pre-treatment or even during the stimulation cycle to get the maximum number of oocytes. And again, this has also come from the Cochrane, which shows that growth hormone has improved live birth rate, at least in these particular group. Androgen pre-treatment, let it be DHEA, let it be testosterone, both of them have actually proven to improve the number of oocytes that you're able to procure from the patient. And what is the rationalization? Everything has a rationalization. Nothing is being given without context. Everything, like I said, even when we're talking about androgens, you have insulin-like growth factor that helps in terms of the oocyte and the follicle maturation. Coming to the trigger. So we spoke about how do you identify them. How do you suggest various options so that they do not become infertile, but they still have a potential in terms of fertility preservation. Second, once you have a woman who's already a poor ovarian reserve, you have at least 4 or 5 adjuvants that you can give them in the previous cycle so that their cycle outcomes are better. Cycle, when it comes to the cycle, no protocol is any different. Addition of growth hormone, LH, is important for you to get the best quality oocytes. Finally, when we come to the trigger, again, very clear definitions and data which tells us that we're going for a dual trigger. A dual trigger is where you're giving an agonist and a HCG together to give you the best outcomes in terms of maturation. Why? You're giving an agonist. Agonist immediately in about 4 hours increases your LH, and just as equally fast it brings it down as well. Whereas HCG takes a longer time to get the LH, surge, stays for a bit longer, and then comes down. So when you're adding both of them, you're getting the best in terms of both the medications. So a quick surge, continuous surge with the HCG, and then that helps in terms of the oocyte maturity and recovery as well. Now here again, there are different ways that we can look at the dosage, but agonist dosage, if you're based on whether you're giving a leupride or a triptorelin oil, it's either 0.1, 0.2 to 1 to 2 milligrams of leupride. HCG, again, it doesn't matter whether you're giving a urinary product or you're giving a recombinant product, there hasn't been shown to be any difference. So based on the finances, you can choose. And again, the dosage is between 5,000 to 10,000. Remember, we are not concerned about OHSs. We wish we were concerned about OHSs in this group. They don't have enough follicles to consider OHSs. So your trigger should not be, thinking about OHSs. I'll give them only agonist, or I'll give little dose of 3,000 or no. Give them whatever you can, because the outcome depends on what you're giving as a trigger. And it's also important to time your oocyte retrieval after 35 hours. So you're giving as much possible time for the oocytes to mature. Now, suppose you're getting less numbers. What do? Obviously, pulling off and oocytes. Now, yes, this is, finance very sensitive in terms of how much a patient can afford. So this is where, when you're considering multiples, see whether you can reduce their cost in the kind of gonadotropins that you're giving them and the dosage, so that at least they have the possibility of going for the cycle. So you have to see from the patient's point of view, what would be the best outcome? How can we reduce the financial burden as well? So less ET cancellations when you go for pooling, they will definitely reduce your dropout rate. Psychological distress, the fact that repeated failure is not getting enough oocytes, higher live birth rate. Obviously, each oocyte can give you a 5% live birth. So each oocyte is very important. Obviously, disadvantages are that it's a costly estimation. So at Oasis, the most I think change that we have seen in the last decade is identifying these women, giving them the right kind of counseling, and also look at the option of double stimulation. Now, in double stimulation, and has been proven in a lot of data, to say that pooling of embryos with a double stimulation is obviously the way to go, at least in women with poor ovarian reserve. What are the advantages? Like we said, in a short period of time, you are trying to gather as many oocytes as possible. Now, what is the concept of double stimulation? Now, like I said, in these people, there are both. Reserve is less, some of them are even poor response. So what needs to happen is, if you're seeing 10 follicles, but only 4 or 5 have responded, and the other 4 or 5 have not responded, that doesn't mean that they will not respond in the future. They're just taking longer to get sensitive to the FSH that is being produced. So once you extract the 5 follicles and the 5 oocytes, the other 5 follicles can actually undergo double stimulation. So after the extraction, you give them a day or two break, and then you restart in the luteal phase another stimulation. So in 1 month, in one menstrual cycle, these women can undergo 2 stimulations and 2 extractions. So follicular stimulation and extraction, as well as a luteal phase stimulation and extraction. Just to elaborate on my point, we have a few case reports. We have a 36-year-old. She had a miscarriage prior, but look at her FSH, it's 27. AMH is 0.8. She only has 2 follicles. Now we started. This is how she responded the first time round. We got 2 oocytes, only one fertilized. Unfortunately, that went on to give us a blastocyst. But after that, when we were looking at her follicles, we this time found 3 and 2. Initially, it was only 2. But after 15 days, we could see the smaller, non-visible follicles also growing and getting up to around 7. So we had another 5 follicles in total. So we continued the stimulation, and look at this response in the luteal phase. Same patient, same result, all the reports are the same, but the same woman, see how different her though the parameters were the same, how her response changed in the luteal phase. Obviously, she had 2 day 5 blastocysts. Now this woman, 39. Again, when we really looked at it, was how her response was. We hardly had any response in her right only. It was only in her left. So we went on, we retrieved it, and then we continued with the dual stimulation. Yes. Now look at that patient and look at this patient. Here, the follicular stimulation was better than the luteal stimulation. But like I said, each oocyte was important. So we went on, we got 3 additional oocytes than the follicular phase, and we ended up having more embryos. 44-year-old woman. Ideally, anybody crossing 42, you have to tell them that their chances of live birth is less than 10%. But there are some very stubborn and very energetic, older woman, 44, refuses to have donor. She says, I've already got a child. With my own eggs, I want to still try. Look at her FSH, look at her AMH and her AFC, which is only 3. And the husband also needed visa just to compound the problems that this woman has. Now, this is her first follicular stimulation, in which she actually went on to 14 days of stimulation before we managed to retrieve 5 oocytes. And then we move on towards continuing the dual stimulation. Now, these are the different ways that we can salvage a cycle. What am I trying to say? Even though an FSH is high, if you're seeing follicles, stimulation can still be attempted. Yes, anybody who's crossing 37, 38, PGT is definitely an option in terms of any point. Because we know it's not just about getting the oocytes, it's about ensuring that the woman has a live birth. As fertility specialists, just seeing those 2 lines on a strip is not our goal. Our goal is the mother going home to the baby, just as it is for the obstetrician. So for us to enable that journey, it is also to reduce the risk of miscarriages. And how do we do that? Once the embryos are formed, blastocysts, PGT, enable which are the ones which are euploid, not aneuploid, and then go ahead with the transfer. And what we have seen is that if there's a 30% miscarriage rate in a woman who's crossing 37, 38, it comes down to less than 10% in women who have had a euploid transfer. So you're bringing the miscarriage down by about 60%. Now, when we are talking about this, what are the things that we can suggest for them in the future in terms of low ovarian reserve? We are looking at oocyte activation. So there are some oocytes which, because of the fact that their mitochondria or the cellular organelles are not optimized, and which is why we tend to get atresia or we don't get embryos. What we want to do is see whether we can activate these oocytes. So what is happening? You're having the same gene code. You're not changing. We are not going for donor. It is their own gene which is coming from the nucleolus. But what we are changing is a cellular complement. We are activating the oocytes so that fertilization and development to a blastocyst of their own oocyte and genetic material can be done. We're also looking at ovarian tissue vitrification. So when we are talking about, just this evening, we got a case from one of the oncology centers. 22-year-old girl. She had a oophorectomy for torsion. She now comes back with a cyst on the remaining ovary. The cyst is 6 centimeters. When the oncologist, they open up, they'll remove you. Simple. They will not think twice. For them, life. Quality of life, they will think later. this whole concept of quality of life, family building, and all of that is not there in their scheme. They haven't been told that. So before, thankfully, one of the oncologists is a young chap who's been drilled with this fertility preservation. So he sends them all to us. What are we doing? We're going for a stimulation, random start stimulation. We'll extract whatever oocytes we can, and then she goes back for definitive surgery. They'll do a frozen section, and based on what the frozen section is, they'll decide on whether they keep the ovary or not. But a 22-year-old woman, rather than her becoming completely sterile, you're giving her the possibility. The next step is, now a 22-year-old woman, if you're removing both the ovaries, what tends to happen? Premature ovarian insufficiency. Let's keep fertility aside for a second. Premature ovarian insufficiency. In fact, she's going to be in failure. What will she need? HRT. How many gynecologists are ready to give HRT nowadays? We should, but are we there yet? No. What is a possibility is to actually strip any normal ovarian tissue, vitrify it. If she goes into failure, you take this tissue, you re-implant it in the ovarian fossa. Not only can she have her own oocytes, she will also be able to be hormonally balanced. She will not need HRT. So that's the next step that we should be looking at. In fact, they're also looking at this for people in menopause. So if I had frozen my tissue when I was in my 30s, once I crossed 50, I would have not needed HRT. I wouldn't have had the side effects. So what, my mother had breast cancer. I have difficulty in considering HRT. But if I had a tissue, I wouldn't need to. I wouldn't need to take HRT. All the downsides of all the HRT can be done away with if you are looking at oocyte vitrification. So that's where the field is progressing. We are not just talking about fertility when we are talking about reproductive medicine. We are talking about the whole gamut, right from adolescent to menopause. Ovarian rejuvenation. How many people do we see coming back with, youngsters coming down with low ovarian reserve? Intra-ovarian stem cell, PRP. We are not there yet, but these are some of the things that we're considering in the future for this very difficult but very, prevalent group of patients. Conclusions: young women with low reserve do better than old women with a normal reserve. Age, always remember that. In women with low ovarian response, no differences exist in terms of safety and efficacy between the different protocols. Higher dosage is not required. And consider dual stimulation and pull up more oocytes so that you can give them a good outcome. Choosing recombinant over other gonadotropins not required. Please consider adding LH to an FSH and look at all the adjuvants that we spoke about. Dual stim, like we said, is promising, and cooling of embryos, at least in this group of people, is very important so that you can do away with donor killings. Thank you.
Thank you, ma'am. That was really very enlightening and very crisp and clear talk. Thank you very much for having me here today. Any doubts or questions from the audience? Welcome. Now, let's go for the next session. The most interesting topic by Dr. Naseema Reddy sir. I would like to invite Dr. Naseema Reddy sir for his presentation. Sir needs no introduction. It's a very honor to introduce you, sir, today. Dr. Naseema Reddy sir is the managing director at Warangal Hospital Private Limited in a 100-bedded private hospital established in 2007. His theoretical command comes by having worked as a professor at Kakatiya Medical College for 5 years, working at CKM Government Maternity Hospital for 18 years, and vice centered a private clinic in Warangal for 10 years. Has strengthened his approach to solve cases of infertility manifold. So, sir is going to talk on congenital uterine anomalies. Over to you, sir.
Full speed. Full speed.
Good evening, everybody. After hearing Dr. Madam, it is definitely very difficult for anyone to talk because after hearing a very interesting and thought-provoking talk, probably I may be talking to you the one which is very much nearer to our clinical practice, because Madam has spoken about the intricacies and management of a fertile woman who has got low reserve. Probably it is beyond my scope of my knowledge, because when I got my post-graduation, we never thought of anything called like a anti-Mullerian hormone. Only in those days we used to do only FSH. That too very rarely, because it was not even available, but it is available only in the metros. The vast explosion of the knowledge in the field of endocrinology has brought many changes, or the life changed the life of many of the infertile couples, thanks to the reproductive medicine people. But coming to the fact, I'll be speaking to you to the age-old problem. It is there, it is going to be there, it has to be corrected. So I'll speak to you on the different aspects which has changed over the years. The anatomy is the same, but the classification, the management, diagnosis has changed in the recent years. The one which I am going to talk to you is the same. I'll talk to you in a simple way so that you can remember few of the things, because it is very difficult for all of us to remember all those images and all the things have been written in the textbooks. But definitely I will try to limit myself to the few things which you can deal at your pace. Coming to the prevalence, it has been told that something between 0.6 to 38. It is quite unusual for us to assimilate. So I have chosen one study which is nearer to the normal. I think 5% in the unselected population. Yes, we do see 8% in infertile women. Yes, we do see 10 to 12% sometimes. 13% in those women, or somewhere around 15%, which is just remember, recurrent miscarriage. The miscarriage rate usually around 15% in the normal population. Similarly, any miscarriage woman, the uterine anomaly rate is approximately same 15%. So on the whole, when you put together miscarriage and infertile couple together, it comes to 25%. 1 out of 4 patients, probably you may be having some anomaly related to the anatomy of the uterine cavity. So please remember, so subtle changes, subtle anomalies, one has to find out in these group of women who are infertile and miscarriage. Don't ignore them. Just investigate in detail. You will find some subtle changes in the uterine cavity. Coming to the embryology, because I did not have to teach you about the embryology, but for completion's sake, I'll put it in simple way. Mullerian ductor, that's are the we are going to develop into the uterine and fallopian tube and the cervix and the upper vagina. And vaginal bulb will be the one which causes the lower vagina. So, three things one has to remember. In the first phase, usually these ducts elongate and canalize. In the second phase, these ducts, they come together or rather fuse together. In the third phase, what will happen? The fused part of the Mullerian duct reabsorbs or resorbs. So that is, in short, is the formation of the uterine in the cervix and the fallopian tubes. So we will ignore about the upper part of the Mullerian duct, that is a fallopian duct anomalies and all other things. Then coming to the same thing, what type of defect will cause what part of the uterine cavity being abnormal. So we will go one by one. There's a formation of the Mullerian ducts. There is a Mullerian agenesis or part of the Mullerian duct has not formed that results in the failure to develop bilateral Mullerian ducts. That is, otherwise you call it as an MRKS syndrome, because there is no uterus, but even the two bulbs which are there or the rudimentary, or sometimes you will see in the MRKS syndrome, when you do laparoscopy, some buds, some fibrous tissue sitting on the lateral wall of the uterus, just adjacent to the ovaries, because ovaries also laterally, very much laterally placed in cases of MRKS syndrome. And failure of the one part of the Mullerian duct naturally results in the unicornate uterus. That is, as far as the aplasia or the failure to form is concerned. Second one is comes to the fusion. A little bit tricky here it is. Horizontal fusion defect, that is, otherwise results in the bicornate uterus and uterus didelphus. But the vertical fusion defects, especially involving the sinovaginal bulb, will result in the transverse or the vertical septa. This I will come to it later. And the third one about the resorption, failure to absorb. So this absorption results in the septate uterus. Sometimes we may even the arterial, of course, arterial is a debatable subject right now, but still that also will comes under the failure of the resorption. So all the things have been said. How do you classify? Because a lot of classifications are available in our textbooks. The most recent one probably may be the good one for a clinician who wants to correct these anomalies, who wants to treat these anomalies. Probably the best one comes to my mind. I don't know whether infertility specialist will agree to meet or not. As an basic gynecologist, I prefer to use this classification because it is simple and it gives clear-cut information. Say Mullerian agenesis, that is MRKS and all other things. If the cervix is absent, specifically they have mentioned cervical agenesis. Unicornate uterus, that is also comes under agenesis. Uterus didelphus, this is again a resorption defect. Bicornate uterus, this is also resorption defect. Septate uterus, this is also one resorption defect. Same thing longitudinal vaginal lab, and there is an entity called complex anomalies where you cannot put. Sometimes you will see some septum, some corporeal indentation. Sometimes uterus, unicornate uterus, and other abnormalities, other RNAs present and all. Because where you can't able to label, this comes under complex anomalies where the upper vagina is completely absent. This is the same thing has been mentioned about it. The left upper one deals about the aplasia. The right upper one deals about the septate uterus and the vaginal septum. This is a resorption defect. The lower right one deals about the biconjugate uterus, which is the fusion defect. Uterus diadelphus, again it's a fusion defect. Then the vaginal septum and the transverse vaginal septum, because they may be unilateral or by and in the right or left or something like that septum. These complex anomalies, you can't only mention about how they are there, because you can't put it under any category. Other one which I like, I think all the infertility specialists, they may like to use this type of classification because it is simple for many of us to do, because this is also is good. But as a clinician, I prefer to use the ASRM, but the infertility infertilologists, they prefer to use this history or the recommended by the endoscopic society. European Society of Gynecological Endoscopy, which has categorized into 6 categories from U0 to U5. I'll elaborate this one later. Coming to the diagnosis, how are you going to diagnose these anomalies? Clinically, by vaginal examination, you can diagnose vaginal septum or hematometra, unilateral hematometra, something like that. Then the gold standard, which used to be even still today, is the HSG, sonosalpingography, USG, MRI, and hysterolaparoscopy. These are the candidates which are available to us. Coming to the simple one, which because you may be using this in day in and day out, is a good screening test for all the congenital uterine anomalies. You try to do the HSG, is the gold standard. Of course, if you have the sonosalpingography and you are expert in it, that is also gives you good information. Besides the uterine abnormality, even you can evaluate the fallopian tubes also at the same time. But whatever I say, I prefer to do HSG as far as the uterine anomaly is concerned. The angle of difference of the uterine horns of less than 75% goes in favor of septate uterus. If it is a divergent angle more than 105 degrees, it goes more in favor of biconjugate uterus. This is a rule. That doesn't mean that all the uterine angle is more than not 5, need not be biconjugate. Sometimes broad septum may give rise to this type of picture. So there is a overlap. But for theoretical purposes, this has been evaluated like this. HSG, all of us know that it cannot differentiate between the septate and biconjugate uteri because of its limitation in evaluating the external contour, because you will not be able to see the contour. Coming to the, again, another simple method of evaluating the uterine anomaly, because which is available to our in our clinic. I'll start with the B mode. Never jump into the 3D, because B mode 2-dimensional ultrasound itself will give you lot of clues. One thing, it is of course less expensive now, because every gynecologist has got a transvaginal probe in his or her clinic, I hope. So when you have to do ultrasound, when you are suspecting a uterine anomaly, don't try to evaluate uterus in the proliferatory phase when you suspect a uterine anomaly. Better postpone till to the secretory phase. Do it in the secretory phase. Why? Because in the secretory phase, the endometrium is very shiny. Whatever you do, even with your probe movements itself, it attracts your attention. Where is the country? Even the rudimentary horns sometimes can be picked up very well when you do ultrasound in the secretory phase of the cycle. Then coming to the what is this double endometrial complex sign? In the axial plane, the differential diagnosis would be in the axial plane. When you do ultrasound, you will be able to see two endometrial hyperechogenic complexes. When you see in one plane itself two endometrial complexes separated by a myometrium or some intermediate tissue, think that definitely there will be some abnormality in the uterine cavity. Don't jump that it is the circulate uterus, it is the bicornuate uterus, or the uterine diatomos. Because in all these three scenarios, you will see two endometrial complexes in the axial plane. So in the scenario, you have to do further evaluation or the deep study of the pelvis, either with the 3D or with the B mode itself with the manipulation of your probe, or sometimes you can go for the MRI. Then coming to the another one, which attracts your attention is the when you see only endometrial complex, one endometrial complex, you will not be able to see the angles, because whenever you try to see the both angles of the corner of the uterus, always it directs to the one side, and the majority of the times uterus will be deviated to the one side. So this is the one where in the axial plane how the endometrial echo looks like, because it is here you will not be able to see the two ostia. It is not pointing towards the two ostia. Even sometimes you can see the rudimentary horn also with a small endometrial lining, but it is not non-functioning. It is not non-functioning, but still you will be able to see the small white line in the rudimentary horn. But it is a tricky. It's not that you will be able to make out in all cases of the non-functioning rudimentary horns by B mode. Coming to the most important aspect of this diagnosis of the uterine anomalies is 3D ultrasound. Of course, one can say that it's the gold standard tool. It facilitates simultaneous visualization of both external and the internal contours, and its unique feature of providing the coronal plane. Because what is this coronal plane? Because see, we are used to do one sagittal plane and axial plane, but very rarely we will get a coronal plane if the uterus is almost straight, neither in the anteverted nor in the retroverted. If it is straight in the pelvis, once you put your transducer, sometimes you will suddenly see that uterine cavity like as we see in the HSG picture. But it's not always possible in all the cases, because many of the uteri either anteverted or retroverted. So in this, we will make use of the 3D ultrasound to get this coronal plane. The cornerstone of the 3D ultrasound is to get coronal plane. What is this multiplanar image? This is nothing but you will be able to see after acquiring a volume of the uterine cavity. So you will be able to see three planes simultaneously. One is the longitudinal, the sagittal, other one is the axial, but third one, it is a reconstruction. It is not a live image. It is a reconstructed image. You will be seeing on the coronal image, that is on the C. What is this rendered image? Rendered image is nothing but a thick image, because a lot of slices have put together to make it attractive to your eye. This is a rendered image. So rendered image or the 3D image is nothing but a complex, a bundle of coronal images. So cornerstone of this 3D ultrasound is nothing but it is only coronal image. How you can see some of these pictures, normal uterus, in a 3D subseptate, and the complete septum, bicornate, and the unicornate, and the dysmorphic uterus. Then what are the things one has to look at after acquiring 3D image? So it is very attractive for us. And the limitations of the 3D are very, very minimal because artifacts have been excluded many times by 3D image because it is acquires the 3D images, amalgamates the 2D as well as the axial and the coronal image. So what the things one has to look at in the 3D image? One has to look at the contour of the uterine cavity. That one should not miss. That is the important aspect. Then, what are the things have to be measured? So one has to measure the thickness of the myometrium or the uterine wall thickness. Usually, when you don't have the 3D 3D probe or something like that, usually in the sagittal plane, late sagittal plane, you can acquire the thickness of the myometrium in the broader area of the uterus from the endomyometrial junction to the serosal junction. That is the thickness usually you do it. But in a 3D acquisition, usually you will be measuring the myometrial thickness at the fundal level. So for that, you have to draw a line between the two ostia. The interosteal line one has to draw. To this interosteal line, you have to draw a line parallel to the surface of the uterus, not the contour of the surface. You have to go to the surface of the uterus, make a straight line parallel to the interosteal line. So that gives you the thickness. That is the thickness between the line above the serosa and the interosteal line is the thickness. This is the wall thickness. And how to diagnose the indentation? That also can be done. So here in this picture, there is some amount of indentation of the myometrium into the uterine cavity. So you have to draw or measure from the interosteal line to the depth of the indentation. So that gives you the indentation depth. So if it is more than 5 millimeters, whatever it may be, you have to write it down. So that gives you differentiate between the subseptate uterus and the archaeotic. So that I will come to you. These are some of the diagnostic criteria have been used over the years, saying that the subjective impression clinically relevant. The most recent ones are the most important ones are commonly used by many of the radiologists and the gynecologists or the fertility specialists is the one ASRM 2021 at the same time ASRM 2016. When you do these two things, sometimes the words go for my. So, and another one is the history classification also, the wall thickness, if the ratio is more than. But I will make it very simple. Please, for time being, remember the ASRM one. That the septal angle less than 90 degrees and the septal length of more than 10 millimeter, more in favor of septate uterus. This is as far as the septate uterus is concerned. Angle is less than 90 degrees and the septal length more than 10 millimeters. I have told you how to measure the septal length. That is the length and an interosteal line to the peak of the depression. Then coming to the well spoken, it's a controversial, not even controversial, but it is has been diagnosed of late very often by the radiologists on HLC, on ultrasound, on 3D ultrasound, even on MRI also. They are mentioning an entity called as a T-shaped uterus. So once it has been diagnosed, what are the things to say that it is a T-shaped uterus? What to be done? So in this, you have to measure the T angle. That is the angle at the ostium. That should be less than 40 degrees. And the lateral indentation depth, it should be more than 7 millimeters. And the lateral indentation angle more than 130. This I will discuss about it. What is the importance of these measuring these angles? And why should we mention about all these things? Just simply writing T-shaped uterus is not going to serve any purpose, because that can be diagnosed by anyone, because it is looking like a T. Yeah, it is a T-shaped uterus. But the purpose is, can we do something to this uteri? And are we misdiagnosing T-shaped uterus or the infantile uterus uteri as T-shaped uterus? Because anyone attempts and a lateral metroplasty and an infantile uterus, you will be doomed. So I'll tell you what is the difference between the T-shaped uterus and an infantile uteri. This I will skip. Coming to the other classification of X-ray, which is very popular among the infertility specialists. Normal uterus, because I need not have to tell anything. Dysmorphic uterus, because this in the X-ray classification they made it is the next to normal. I don't know why they have put it, because it seems they might have encountered more number of patients in this one, because usually it has been told that septate uterus, biconjugate uterus are more common, but I don't know what reason they have put the U1 as a dysmorphic uterus, because they may be getting more number of dysmorphic uterus of late. So in this, naturally dysmorphic means the smaller than the expected, the size appears a little bit smaller. Fundal contour, as usual, it is normal. Internal indentation should be not more than 50% of uterine wall thickness at the fundus. This is the most important part, because it should not be more than 50% of the wall thickness. However, there is an abnormal shape of the cavern. Kidneys are not linked to it. More renal anomalies have been made out in this. But in this dysmorphic uterus category, you have two things. One is the T-shaped uterus. It is on the upper left. Is called as a T-shaped uterus, and another one is the infantile uterus. Can you make out anything looking at these two? Both, generally speaking, looks like same, isn't it? But the thing is, once you look at the myometrium in the infantile uteri is thin, isn't it? Here the myometrium is thick, but whereas the infantile uterus, the myometrium is very thin. And the body of the uterus in the T-shaped uterus is more than the lower 1/3. But whereas the lower 2/3 of the infantile uterus is sleek compared to the body. So it is an reverse. So whenever you attempt any lateral metroplasty, this is going to be useful, because you can do it. But whereas an infantile uterus, you cannot. Coming to the septate uteri, so it's there is nothing much to talk about it. The indentation should be more than 10 millimeters as per the ASRM guidelines. The same thing is been, it's more than 50% of the uterine width, wall thickness, and here it has been. But most of the times as a clinician, we will take it as more than 10 millimeters or more than, sometimes even more than 5 millimeters also sometimes. In a cases where there is a recurrent pregnancy loss, where there is a history, sometimes pregnancy loss, and there is a long standing of infertility, we can make a diagnosis and we can correct it. Here, the important thing is one has to remember is the bicornuate uterus or bicornuate uteri are associated with renal anomalies to extent of 15 to 25%, or sometimes some of the texts have mentioned even 45% of the times. but depending upon the uterine anomaly. But the renal anomalies are associated with two things. One is with the separate uteri and the biconjugate uteri. In the subclass 1, it is a subseparate uterus, and the subclass 2, U2B, divides the uterine cavity up to the level of the internal cervical arch. When do you call it a complete septum? When do you call it as a subseptum? There should be, whatever it may be, even the 2 centimeters septum, it is not even touching the internal arch, can be classified, should be classified as a subseptum only. If it is up to the internal arch, then only you should call it as a complete septum. Okay, is it clear? Then coming to the biconjugate uterus. Now we are not calling it as a Israel is not calling it as a biconjugate. Corn means tongue or 2 horns. So here they are calling it as a bicorporeal. That means 2 bodies of the uterus. Because muscle tissue is intact, 2 horns, the musculature is intact. So they are calling it as a bicorporeal uteri. So this is again divided into 3. The indentation not reaching the cervix and no septum, that means less than 150% of the uterine wall thickness. This is called as a subclass U3A. And another U3B, indentation reaching up to the level of the cervix, possibly including the cervix and vagina. In 75% of these patients, they are associated with the vaginal septum. And the U3C, there is the bicorporeal septate uterus. What is this? Again, another confusing terminology. We are mixed bicorporeal, again septate uterus. Is it biconjugate uterus or biconjugate septate uterus or the septate uterus? Again, is that. So this entity clarifies when one should call it as a subclass U3C, otherwise called as a bicorporeal septate uterus. Sometimes it has happened to the clinician, whether it is a biconjugate uterus or septate uterus, even whatever you may be doing, even the best of the best knowledges or the MRI reports also have a lot of confusion, because this gives a clarification about this. So indentation not reaching the cervix in combination with the septum, that is more than 150% of the uterine wall thickness. In 25% of the longitudinal vaginal septum is present in these patients. When the fusion of the mullerian ducts fails, a corporeal uterus is encountered, also known as a biconjugate uterus. So simply you can say biconjugate uterus and bicorporeal septate uterus, because this is a one where you have to differentiate between. Sometimes they confuse you. Nothing much to say about the uniconjugate uterus or the hemiuterus. This is associated with the rudimentary, communicating, non-communicating, functioning or non-functioning uterine horns. Another one, aplastic uterus, aplasias, maybe both the mullerian duct have aplasia, or sometimes there may be some bud-like tissues may be seen in the pelvic cavity. Then coming to the other one, where we have confusion. We haven't come to any conclusion that we haven't specified in which category this uterine anomaly falls. So in such a type of scenario where one can make use of MRI. MRI is not mandatory for in all the uterine anomaly cases. 95 to 98% of the times you can diagnose uterine anomalies with the HSC, your beam mode with 3D ultrasound. But remaining 2 to 3% of the patients you require MRI assistance. Where we require it? It is especially you want to know the anomalies associated with the cervix, because endometrial cavity is seen very well in the uterine cavity. Sometimes you may not be able to localize the cervical canal so effectively, because when you take the axial section, sometimes you may not be see the cervix or the cervical mucosa so effectively as we see the endometrial cavity, because sometimes it may be filled with the fluid, sometimes nothing will be there, sometimes echogenic mucosa lining will be there, sometimes it's an isoechogenic, nothing, you can almost see that it is one solid tissue. So in that scenario, MRI is the best, especially suspected complex anomalies where we suspect combination of cervical and vaginal anomalies is the best. Coming to the few words about the management. Should we treat all the anomalies? Definitely no. Where we can do some correction. Coming to the separate uteri, as I mentioned in the beginning itself, these are the varieties. Some repetition may be there. Why we should correct? First of all, should we correct? Then in this case, why we should correct? Is there any evidence that correction of the anomaly leads to the better outcome? There should be some evidence, because this is the era of evidence-based medicine. So there is a fair evidence that uterine septum contributes to miscarriage and preterm birth. That's a grade B recommendation is there. But there are some studies, there are good number of studies. They may say that probably not even treating some of these separate uteri will result in the equal outcome by the treatment group and the non-treated group. But the recommendation is the same, is grade B. There is a fair evidence that you have to correct. Some evidence suggests that uterine septum may increase the risk of other adverse pregnancy outcomes, especially malpresentation, intrauterine growth restriction, placental abruption, and perinatal mortality. Because there is different way of thinking. Usually, the infertility specialists, they limit themselves for the outcome, that's a pregnancy outcome. If the pregnancy lasts till first trimester of pregnancy, they think that almost it is 100% success rate. Or sometimes they see the cardiac activity, they feel that it is 100% success rate as far as their assumption is concerned. But as a clinician or the patient, it is the outcome is being measured by the healthy baby being born, and the patient should leave the hospital with the healthy baby in her lap. So malpresentations and the UGR of placental abruption complication and perinatal mortality is a more concern for us, especially which favors us to treat these patients. Whether it is required or not, but we will be pushed to correct these patients because we are fearing that probably these women may land up in any of these above said problems. So the correction is the hysteroscopic septal resection is the grade C recommendation. Then as far as the complication, differences in the incidence of obstetrical complications when comparing a thick septum more than 1 centimeter or thin septum less than. There is no difference between the thin septum or the thick septum more than 1 or less than 1 centimeter. The complications are the same. These are the old treatments. We used to do this Jones modification, modified Jones operation in early 80s. Of course, the latest one is the hysteroscopic correction. Commonly used techniques for the hysteroscopic correction are the cold scissors, unipolar or bipolar cautery energy, or laser. And the distending media, it all depends upon what the energy you are using. Suppose if you are using monopolar energy, glycine has to be used, or the glucose. Suppose if you are using bipolar energy, normal saline is the medium. And another one is, most of the times, in the olden days, we used to do the septal dissections under laparoscopic guidance because we never used to have the thought that there is an indentation. Because in down the line 10 years back, when the 3D ultrasound was not available, There may be some indentation in the fundus. Probably maybe we may be cutting too far. We may perforate. So that we used to have the guidance of the laparoscopy. But with the advent of 3D ultrasound, MRI, that has gone. But even then, while doing septal dissection, if you have the ultrasound at your hand, please make use of it. Thus, that after septal dissection, you can assess how far you have gone it. Suppose if you have the ultrasound, you are an expert user of ultrasound in the operation theatre. Otherwise, you can make use of the laparoscopy guidance while doing septal dissection, especially thick septa. These are some of the videos available. I'll skip it. Then, after correcting the septum, how long one has to wait? Usually, cavity is healed by 2 months. That is a notion that every one of us have it. But there is no sufficient evidence, whether one should wait for 2 months or 2 cycles or 3 cycles or 6 cycles. Usually, all of us will follow is wait for 2 cycles. This another one, a biconvent bicolis. This is another entity where you will have one cervical canal or where you will have 2 cervical canals. Suppose if you have 2 corpora, 2 bodies and 2 cervical canals, but externally the cervix is only one. But in the cervix, you will have the 2 cervical canals. So how to go about this patient? Especially these patients have miscarriages, repeated miscarriages. That I will explain to you. So first of all, let us know what the biconvulate uteri causes. The preterm labor is the most common complication of the biconvulate uteri. And whenever in these patients, whatever it may be, if the cervix in the first place, though it is closed, though the cervical canal is closed, tightly closed, internal is slightly closed, external also, the sonologist says that the cervix is 25 millimeters. Still, we prefer to do encephaloplasty because the preterm labor is 13 times higher. So you can imagine, preterm labor is 13 times higher in cases of biconvulate uterus. Many of us never thought that biconvulate uterus will have preterm labor to an extent of 13 times, isn't it? Maybe double, maybe 3 times, but it is 13 times higher. And of course, the PPH is also very common any of the uterine anomalies. But we haven't heard of risk of rupture uteri. But we have seen some of the patients where the rupture uterus is a possibility because in the lower part of the cervix where the fusion has taken place, that part has got a fibrous element in this biconvulate uterus. But usually the part where the fusion is, it should be muscular only. When the muscular element is good, there is a least chances of rupture. Whenever there is a fibrous element is there in between the 2 corporea, there is a fair chances of rupture. So in these patients, you have to be very careful while following it up. Especially this can be seen in the early pregnancy. You have to measure the thickness of the wall of the uterine cavity. And another one is you can look for the vasculature also. If it is highly vascular, it is a good sign for that it is a muscle. If it is the least vascular, probably it may be the fibrous element. The association of the renal anomalies, of course, it has been told to you. Especially, is there any rule of unification of these uterine corpora? Yes, surgical intervention with the Strassman metroplasty or cervical insert should be considered in select women with a history of recurrent poor obstetrical outcome. the patient had recurrent pregnancy losses after 5th month of pregnancy. All pregnancy have gone in the 6th or even less than 28 weeks of gestational age. She doesn't have any live child. In this scenario, unification operation is a must. Either it can, if you are an expert, you can do laparoscopically. If you are not expert in laparoscopic suturing, you can do open Strassman surgery, because there is nothing much to say about these two procedures. So who are expert in doing these things can go for it. Open and laparoscopic correction of the Strassman. Then coming to the unicorn weight. Can we do anything to the unicorn weight uterus? Absolutely, one can say that nothing can be done for the uterus. But still there are some things which one has to advise. That is problems with the reproduction were attributed to abnormal uterine vasculature and reduced myometrial mass of the unicornate uterus. So that is the one reason why we are worried about the premature labor. And only one uterine cavity and uterine artery and the limited contribution of the contralateral blood supply. And another one is the diminished muscle mass at the isthmo or cervical corporeal junction or at the isthmus. So the cervical incompetence is more common in the unicornate uteri. Suppose if you are with the functioning rudimentary horn, it has to be excised. There is no second thought about it. The non-functioning rudimentary horn, you need not have to do anything. You are not. But if you are gone for the resection, please resect the non-functioning or the functioning or the rudimentary horn along with the saplings. Tube has to be removed. You need not have to remove the ovary on the other side. The other one aspect, of course, every infertility specialist knows that only single embryo transfer is a rule in cases of unicornate uteri. Of course, I think many of the infertility specialists, they adhere to this concept. Coming to the controversial one, should we correct arcuate uterus or not? Arcuate uterus, when you say that the indentation of the muscle into the uterine cavity less than 5 millimeters, So this should be corrected. See, purists say that no need to correct it. It's a simple indentation. Why do you want to correct it? But there is a scope. There is a reason behind even in correcting the arcuate uteri, especially may be considered. I am using the term may be considered in selected cases with the recurrent pregnancy loss. You have a prominent broad configuration of the fundal myometrium. So how do you say that the fundal myometrium is broad? So it is almost 75% of the length of the uteri is fundal width. Probably if it is associated with the arcuate uterus, it has to be corrected. Why? Because though it is 5 millimeters, less than 5 millimeters into the uterine cavity, but it is broad. It is length is transversely it is very broad. Probably that may be the reason for the recurrent pregnancy loss. So in correcting the arcuate uterus, the fundal measurement is a must. It should be 75% or more than the length of the uterus. MRKS is known to you and you not have to elaborate it. The treatment of choice is nothing but the surrogacy or the uterine transplantation. Coming to the uterine diadelphus. If asymptomatic, nothing can be done for these patients. Surgical correction can be attempted in these patients. Not usually indicated. However, excision of the vaginal septum may be required in the woman is whether asymptomatic or symptomatic. Usually, once you encounter vaginal septum, even in an alliparous woman, even under pregnancy, it is better to excise the vaginal septum because other side of the vagina cavity is associated with the infections because it is not draining properly. So because coitus may be taking place on the other side, most of these women they come with the recurrent vaginal infections. Some of these patients may require surplus. To conclude, uterine congenital anomalies can present varying stages as a primary amenorrhea, infertility, and recurrent abortion and preterm labor. 3D and MRI helps in accurate diagnosis, rule out renal anomalies, histoscopy and laparoscopy whenever it is indicated, corrective surgery in selected cases, cerclage whenever it is indicated in the high-risk patients. To conclude, it is worth looking at the couple in a holistic way. So the diagnostics of both the woman and the man should be expanded, focusing only on the uterine defect as a possible cause of infertility may obscure a proper diagnosis. So usually whenever we encounter an uterine anomaly, we will say that this is the cause for your infertility because that carries lot of misinformation, anxiety in the couple. Please look at the other partner because this may not be the only reason for their infertility. Male may be having some severe oligoasthenoteratospermia, which is more problematic than the uterine anomaly. Because this uterine anomaly you can correct overnight, but you cannot treat an OAD patient, you can give any prognosis to this patient. So communication is a very, very good thing because never explain to the patient that uterine anomaly, you have got a problematic uterus. Never say that, never discourage them. Most of the times, they will come to us saying that, we have a uterine abnormality. It has been known to my in-laws. Everybody is scolding me. My infertility for miscarriages, it is the only reason. Please explain them that you have got a problem. This is correctable. 75 to 80% of the times you can correct these anomalies. They are going to have a very good outcome. But whereas the male factor abnormality, you have got limited chances, very, very poor prognosis and a lengthy procedure too. So in short, I will conclude my lecture saying that this is the best clinical entity where you can do something on your own in your clinic by a basic gynecologist. You may not have to become an expert in this. Just you spend few minutes every day whenever you encounter a patient or being referred by some clinician, some other clinician saying that it's a separate uterus. Please do scan on yourself. Learn from why he has called it as a separate uterus. Why I'm thinking it is being as a biconvatus. That gives you a lot of information that who is teaching to you this way. Thank you very much for patient hearing.
Thank you, sir. That was really very elaborating and very enlightening lecture, sir. Any doubts? So now,
Any questions? No questions? Probably I might have confused you.
very well understood, sir. I think it's all doubts are clear. It's
Say, you have to cut the indented part, the section. There are two terms, excision of the septum and the resection of the septum. Some of them they are using as an interchange terminology. Why they use resection, why they use excision. So excision means you will remove some part of the tissue. Incision means you are cutting it. say septate uterus, it is in a septate uterus. This defect is a resorption, isn't it? Resorption means the muscle tissue which was supposed to be formed by way of fusioning of the nuclear redox remained the same. That means that part is muscular. It is a muscle. Once you cut the muscle, naturally the tendency of the muscle to retract. Isn't it?
Archaea itself.
Archaea is also a muscle. You can cut it. You can incise it. No need of excision. Excision being done if it is a very thick septum is there. It is a muscular. Sometimes you feel that it is some fibrous element is there. Especially in cases of where the bicorporeal and the septate uteri, there is a confusion. Subseptal element is there and bicorporeal element. Because the bicorporeal element will have some fibrous tissue. Whereas the septal tissue, septate uteri, there is nothing in the fibrous tissue. It is only muscle. In those scenarios, you can excise a part of it. The excision is done by the loop. Go to the cavity and remove the part of the tissue. But it's very, very rarely. Maybe I might have done 3 or 4 cases. That too, I abandoned in the first place. Whether I thought that I can't excise with the scissors. Then I abandoned it. Then very next day I posted it with due precautions. So because these are the patients, sometimes they may go in for the pulmonary edema because we may be using a lot of IV fluids because patient also has to be under general anesthesia with the tube endotracheal tube in because majority of the times either short general we are using it or maybe regional local anesthesia. When you are encountering such a wide excision, always prefer to do it under general anesthesia with the endotracheal tube in situ because that makes our life very easy because the moment the bag is stiff, you can stop it. You can stop it rather than measuring and all other things because that is also gives a clue for us. But the best one is the anesthetist. He will tell that the bag I am not able to do it. And another one, never use the what do you call it as anesthetic machines because always instruct your anesthesiologist use mask and manual ventilation only because the manual ventilation the moment the bag is stiff naturally he will come to know that there is an interstitial pressure in the increased interstitial. Then we can abandon it. Whereas if you connect it to the machine, probably by the time it gives an alarm, the time will be lost.
Have you done any cases of Stressman metroplasty?
Not in the recent years, but I did the open specimens. I haven't done any laparoscopic specimens because I am not very good at suturing. So many continuous you have to suture anteriorly and posteriorly. So manipulation and suturing skills has to be very effective to do it.
Chances of rupture
Chances of rupture are more in either way. Either way, chances of rupture because in these patients, if the patient conceives, always better to deliver around 32 plus weeks of gestational age. Don't even wait for 34 weeks. Please don't wait. By the time you give magnesium sulfate to you, antenatal steroids have to be given, better deliver it as a precautionary measure because the outcome is better rather than having a rupture uteri and we will be losing both the baby as well as losing the uterus itself. Because once the Stressman rupture takes place, you can't repair. You have to do hysterectomy even after repairing only for the purpose of the aesthetic. That means the patient will have a menstrual cycle. But reproductive function has to be abandoned once the scar rupture takes place after Stressman. I did 2 cases, but long back, not in the recent past. Not in 20s, maybe 2004 or 5. But
they delivered. They
Yeah.
had pregnancy and delivered.
But that patient, I think I remember very well. Second patient, what has happened, I don't remember. But the first patient, she had PROM around 29-30 weeks of gestation. We delivered it, But in those days, the antenatal care, neonatal care is very, we shifted the baby to Nilofer. Because in those days, Nilofer is the only one where they used to have a son. The baby was there for 3 months. They said that the milestones were very poor after. So baby survived, but then survived with the problem of decreased milestones.
Any difficulty in delivering the baby while doing the cesarean section?
No, nothing.
Because there is a lot of
Just like just like hysterectomy. When you have done hysterectomy, previously we used to do vertical hysterectomy. Hysterectomy means always it used to be the vertical. But now the concept has been changed. Even if you do hysterectomy, lower transverse incision only. Lower transverse incision only. No vertical incision. Whatever may be the to the best possible down, you go give transverse incision, deliver the baby. Majority of the times, hysterectomy is being done for the non-survival babies only. Is it? No. In those patients, always do a lower transverse hysterectomy. The vertical incision on the uterus for the hysterectomy sake has to be abandoned. Maybe the 2-3 centimeters or 4 centimeter incision in the lower segment, whatever the possible lower side, you go inside and deliver the baby. And one thing when you are attempting it, please ask your anesthesiologist to give 0.5% halogen. 0.5%. That is a very good uterine muscle relaxant. Only problem with that one is the little bit excessive vaginal bleeding. But the moment you deliver the baby, the baby, they can cut it off. 0.5% halogen, no spinal anesthesia, no other muscle relaxant will give you this one. You insist the anesthesiologist to give 0.5% halogen, bag and mask, or even the open inhalation anesthesia. That is inhalation only. At that time, the patient is under spinal. Okay, doesn't matter. Ask him to give 0.5% halogen, relaxes the muscle inside the uterus, deliver the baby, and once the baby being delivered, ask him to cut it off. Very good. Because so that you can go to the lowest part of the uterus, as low as possible. You can go. That relaxes because the muscle relaxes very well, and the removal of the baby is also, it will be easy for you. Even the placental removal is also very good. Even for the retained placenta, always use 5% halogen inhalation only. No other anesthesia will give you sufficient relaxation of the uterus.
Thank you very much. Next, most awaiting and most interesting and exciting quiz program by Dr. Jigna. She is a clinical head at Oasis Fertility Center. Over to you, Jigna.
I think after extensive academic sessions that we have had, the quiz is going to be a little fun time to lighten up and a little bit of exam for all of us. So there's QR codes that are placed on all of your tables. Please scan the QR code with your mobile phone. I think some of you have already attempted the quiz. So please scan it, and once you scan, the quiz starts. Each question has one most appropriate answer, which you need to take, and the timer will start. Once you enter the quiz, the timer starts, and as soon as the timer is done, you need to, the quiz will submit the completion, or if you have completed, just submit. Okay, there's no negative marking. Okay, so the timer is actually for 15 minutes, but I'm sure all of you will finish it in 5 to 10 minutes because I know all of you are very hungry now. I've also prepared the answers. Is it easy, the quiz, or anybody finding any difficulty? For those who have already given. I'll answer your questions once everybody is done. after 10 minutes, we'll start the discussion. Sorry. Please tell me when it's 10 minutes. Anybody facing any difficulty in scanning the image or anything? Pardon, ma'am? It's not. There's another link, ma'am.
Man. खाना खाने बिता दें क्या लोग? At least start.
All of you done? We need some more time.
हाँ चल रहा हूँ क्या तुम भाईगा तुम सामने कर दे रहे चल रहा क्यों क्यों हाँ एक साल पिछले वर्ष में तो तू फोन कर देते तो फिर चल रहा चल रहा यार प्रोजेक्ट का मैं बाहर के लिए इवेंट इंडस्ट्री में सीखने आई थी बाहर के लिए हेलो यार सबका खराब है अपना भी खराब है नहीं सुनो लो खाना खिला दो 4 लोग नहीं जाओ बोलो ये पैसे जाके खर्चा हो आप तो खाने के लिए 4 लोग आप पर आओ कंपनी बेस हो गए तो चारों जान टाइम 6 बजे की
स्पीड नहीं है
एग्जाम बहुत हो गया चार
का निकाल अरे 94 ऐसे रखो वो लाइव में जाना से
94 हो गया
94 24 7 ऐसा
फुल स्पीड हमारा चैनल सुबह फुल स्पीड होता है ये भी वैसे चल रहा है फुल स्पीड आ रहा है थोड़ा स्पीड है फुल स्पीड है थोड़ा स्पीड है
Everybody is hungry, no extra time. No additional sheets, no extra time. Three attempts. Even a network problem, I think 2 minutes. 3 attempts. Last 3 minutes.
आवाज आती है
ऑफ करके फीचर तो नहीं आता
For the timer. All of you, please keep your phones aside now. Okay, I start with the explanation. I'm sure most of you would have tracked it. Okay, the first one. One says dermoids. Okay, typical cotton wool tuft. The other appearances of dermoid that we can also see, there can be a white ball appearance, as you can see on the right side, starry sky sign or white bright lines and dots. Typical bowel looking. Any adnexal structure which looks like a bowel, you should be suspicious about dermoid. This hydrosalpinx is very straightforward. Okay, so whenever we describe any tubal pathology on ultrasound, these 5 points should always be mentioned. The shape, the wall structure, what is the thickness of the wall, extension to the ovary, because you want to make sure it's not a tubo-ovarian mass, and any fluid in POD. So if there's peritoneal inclusion cyst, it goes in favor of chronic, condition. If there's a lot of acute inflammatory fluid, you will not see peritoneal cysts. Okay? This one, PCO we all know, but as per the ESHRE guidelines, FNPS in a 2D static image, FNPS of more than or equal to 10. Okay, and dynamic when we are screening the ovary, FNPO greater than or equal to 20. This is benign endometrial polyp because smooth margins, okay, and bright edge shadow is there. And feeder vessel sign. Feeder vessel sign is very important feature of an endometrial polyp. This fibroid. This is a fibroid. Okay, regular, lobulated, well-defined, smooth margins with internal linear shadowing and edge shadows. The flow, as we all know, is circumferential. Endometrium is not seen within the structure. So that helps us to differentiate between adenomyosis and fibroid. And junctional zone abnormalities will not be seen in fibroid, will be seen in adenomyosis. So this is a FIGO classification. I'm not getting into the details because it will take a lot of time. This hemorrhagic cyst, the typical cobweb appearance, hemorrhagic cyst. This one, this is a tricky one. So this is actually a DI nodule. It's a DI nodule which has been measured. Okay, adenomyosis is there. So that's why my instructions were most appropriate. Yeah, it's the most appropriate answer is what we have to say. So this is DI nodule. So as per the new idea, that is in a deep endometriosis association. So this is how, these are the 4 steps in which we need to assess any patient whom we are suspecting deep infiltrating endometriosis. This one, hyperplasia with cystic spaces is there. Okay, so sometimes it's difficult to differentiate a polyp from hyperplasia. So always put your Doppler flows and check. If there's no feeder vessel sign, you know this is not a polyp, it's probably hyperplasia because polyps can also have cysts. This video, what is the video? Yes. This one, luteal phase, yes. Follicular phase. Isthmus. So a lot of winners today, prizes today. Okay, so just a few words about it. Hypoechoic cystic lesion with retained menstrual blood, isthmus. And ideally, we need to measure the residual myometrial thickness in our case because when we are planning subsequent fertility for them, the residual myometrial thickness matters a lot. Okay, because based on that thickness, we suggest them for going for a repair or we can get them a pregnancy. And they are always very notorious because they always come with fluid in endometrium. Very difficult to treat them. This is, sir, just took an extensive class. Arcuate, yes, hardship. Okay. Retained products of conception, yes. Okay, so what important thing you must remember is presence of Doppler flows helps us to confirm that it is an RBOC. But absence does not mean that it's not an RBOC. So that point has to be very carefully noted when we are doing a scan for such patients. Unicorn rate. This. What do you plan to do for her? Wait and watch. Absolutely. Wait and watch. Because endometriotic cysts undergo decidualization. And decidualization very often mimic like some malignant tumor. So when such patients come to us, don't create a panic for them or for ourselves. Nothing is required. Just wait and watch. She can safely deliver. You can follow up the cyst later. So the important thing you need to see is that smooth contours of the papilla. The papilla smooth contour. So that is what differentiates it from malignant. This is ground glass appearance and
వీడియో లైవ్ నడుస్తున్నారు. అవును ఏం కాదు మొత్తాన్ని చూపెడతా.
subseptate. Yes.
ఒకసారి చూపెట్టేస్తే అయిపోయింది.
This one, complete septum. The uterine contour is maintained, so that differentiates it from bicornuate or septate. Since the uterine contour is maintained, it's a complete septum, septum till the internal os. This is, so this as per the Musa consensus, we have to look into these points. Okay? This particular image shows a globular uterus with asymmetric thickening, fan-shaped shadowing is there, as well as, those 3 points are there. Yeah. So there's no interrupted junctional zone and there's no hyperechoic islands that you notice. So this is a 2D image. Actually, when you actually see the uterus in complete 3D view, you will know the actual thing. So based on this particular image, the options are 1 to 5. I hope you all enjoyed the quiz. Thank you, and we'll announce the winners soon. Madam will be here in 5 minutes.
చెప్పండి సార్ అంటే పంపించారు మన ప్రస్తుతం ఇక్కడ ప్రస్తుతం తిన్నాక పంపించారు ఆగరు వాళ్ళు మీటింగ్ అయిపోయినట్టు ఆగరు వెళ్ళిపోతారు ఎవరు సార్ వాళ్ళు మీటింగ్ లో కూర్చున్నారు ఇది లైవ్ ఇట్లా షట్ డౌన్ చేయండి ఒకసారి షట్ డౌన్ లైవ్ నడుస్తుంది అది నడవలేదు సార్ అయిపోయినా చూస్తున్నారు ఉన్నారు ఎవరు ఎవరున్నారు ఎంతమంది ఉన్నారు సార్ సెషన్స్ అయిపోయినాయి సార్ క్లోజ్ చేయండి సార్ నేను నడవడల్లా అందరూ
Hello. Everyone stay back for a group photo, please. PG, stay back.
నేను అయిపోయింది ప్యాక్ చేసి